Cafés, Canals, and Cardiology. That's what you'll get if you're in Amsterdam on the bank holiday weekend in August, because it's the European Society of Cardiology's annual congress. But as people interested in cardiometabolic medicine, we've identified a couple of really key areas that we think is going to have great impact on clinical practice. So one area is the GLP-1s, an area that's constantly evolving in the diabetes world, but now having an impact on patients with heart failure and other cardiovascular diseases as well. And so we've got some really interesting data that's going to be presented on that. And the second area is something which is pretty much bread and butter for primary care, and it's lipid management. And looking at a couple of molecules for which we've got some more data, so looking beyond statin therapy. And I think this will be really interesting given the new targets that we've seen being introduced in QoF this year for cholesterol and lipid management as a whole. So that's what we're going to be focusing on today. So I'm going to hand over to Patrick and Amma to talk through some of the highlights looking at the GLP-1 data.
Thanks, Amrit. I guess the trial we're talking about is the HFpEF trial, or high-dose semaglutide in patients with obesity and heart failure with preserved ejection fraction. We've seen what the SGLT2 inhibitor class has done for cardiology. Initially, type 2 diabetes medications, but the benefits we saw in heart failure have now transferred them to cardiology realms, and certainly seen them in heart failure, reduced ejection fraction, and now HFpEF as well with some of the trials. It's only a matter of time before we looked at GLP-1s as well. And so this is quite an interesting trial, really. It's looking at semaglutide 2.4 milligrams, 2.4 milligrams, yes, that's right, sorry, which is the higher dose, the dose that's used in obesity. And they're looking at the patient with heart failure, preserved ejection fraction. Now you may wonder why not reduced ejection fraction or so. But again, remember, it's people with obesity, the predominant, heart failure they would have would be preserved ejection fraction. So a large proportion of the population. And this trial is looking at people versus placebo compared to semaglutide 2.4 milligrams. And what's interesting for me, actually, with this, and we can talk about this, Patrick, in a way, is that the primary outcome, so the endpoint for this study is actually, it's not hospitalization for heart failure or decongestion, it's actually the KCCQ score, the improvement in the KCCQ score, and weight loss. So looking at weight loss and patient symptoms, which I find quite interesting. It's quite different for a heart failure trial in a way. We've had them before, but I'm just interested in your thoughts on this and what might be the case.
Yeah, it's definitely a weight loss trial because it's over a year, isn't it? And I suppose it's really, we're going to see what the impact of weight loss with using semaglutide will have on the symptoms and function of people who have heart failure with preserved ejection fraction. Whether we're going to really ultimately know if this drug improves cardiac function in here, that's not the primary outcome. So there are other outcomes. I also noticed the 6 minute walking distance was also one of the outcomes. But again, we know these drugs are good at improving mobility, but it is in people who've got obesity or diabetes, for that matter, it improves their quality of life. So my guess is it probably will do, but we'll be then debating the question: is it just the weight loss? But does it really matter if our patients who are significantly overweight, who've got heart failure with preserved ejection fraction, it potentially this gives us another treatment options, assuming this is a positive trial, and I suppose it's just the first one, as you say. This is new stuff.
Are you saying it's a step in the right direction? I had to say that.
It could be, couldn't it? Yeah, it could well be a step forward. Yes,
I think that's an important point, actually, because of what they're looking at. I think for me, that would be saying, well, in people who have that dual comorbidity that we find out, then this has its benefits. Yes, of course, you're probably using it more for the weight loss perspective, but in the group who also have that added comorbidity of heart failure, then this may have also more of a reason to utilize it. And I think that's probably why I see that in that way. I mean, I guess you said mechanistic studies. I think that'd be very interesting to look at the mechanistic reasons for it. I mean, have they mentioned anything about the mechanisms of I guess they've mentioned why obesity puts people at higher risk of HFpEF.
Yeah, well, there's a paper which we'll no doubt tweet, which has got those baseline characteristics and the design. So it's so that within that, there's lots of different mechanisms. It has to be said, a lot of those are to do with weight, either direct or indirect. So, inflammation is listed there. But it's a short study. I mean, we could speculate the benefits we'd see with heart failure with reduced ejection fraction, but that would take longer, I suspect. And of course, this is all potentially catching. We've yet to see the detail behind SELECT, but this is the same dose of the same molecule, which showed a 20% reduction in overall mortality. 20% in the primary outcome, which was 3-point MACE. We don't know what was driving it, but yeah. So it's, as you say, it's a potential step forward.
Guys, do you think, are there any challenges in this cohort of patients with heart failure using a GLP-1? Is there anything that you're concerned about? I mean, just on a very superficial level, perhaps right now we're in the midst of obviously a supply issue with GLP-1s. But beyond that, is there anything else that you'd be a little bit wary of?
I guess only if you use it from I'm talking it from a clinical point of view. Sorry, I've come in there, Patrick. But if you look at the increase in heart rate with GLP-1s, you wonder if there's going to be any sign there that increased heart rate would cause anything. I'm not convinced that will, but it's just something. If you ask me, if there was one thing that'd be interesting to see, would that have any impact in that group?
I mean, the average age in this group was about 70. So, I mean, I suspect nobody's got frailty, but in the real world, there's a lot of my patients with heart failure, preserved ejection fraction, have often had not only long-standing obesity, long-standing diabetes, hypertension. There can well be an element of frailty, and of course, there's always, we're still debating the benefits in that sort of frail cohort of SGLT2 inhibitors. So is this just adds further fuel? I mean, it's your area of expertise.
A very interesting point, which I sort of missed after you mentioned that, actually. But yes, sarcopenic obesity, because we know the impact of that. We know actually there are a few medications which have looked at that and found potential benefits in. Well, we know heart failure can improve if you improve heart failure management and care, you can improve frailty status in the population. So again, there's a lot of research looking at GLP-1s in that group and in frailty and skeletal mass and muscle mass. So again, that's another area that I wonder if post-hoc analyses would show something interesting. Yeah, that's a very good point, Patrick. I'm intrigued by that as well. Speaking of which, actually, post-hoc analyses, there is another one that's linked on to this. We are talking about GLP-1s, and there's another session actually looking at GLP-1s and the heart, so diabetes in the heart, and it's a post-hoc analysis. That's what jogged my memory. It's looking at the SUSTAIN 6 trial, which remember was the cardiovascular outcome trial for semaglutide, and it was looking at the effect of once weekly semaglutide on MACE in patients with type 2 diabetes and polyvascular disease, so perhaps a higher risk cohort, which to see whether there's added benefit or there's more significant improvements in MACE reduction in that group. And this is sustained, so it's the type 2 diabetes dose, which is the lower dose semaglutide, 0.5 and 1 milligram.
Moving on from that, an area that I think would be quite interesting, particularly for primary care, is lipid management. And there are a few studies that are being presented at the Congress looking at non-statin therapies. And I think this is really important for primary care because it's just the vast numbers of patients who we have on lipid-lowering therapy for primary prevention, perhaps in certain cases, but certainly in secondary prevention. And I think this year it's quite interesting for primary care because we've got some new targets, haven't we, from QoF, looking at non-HDL levels and LDL levels as well. So non-HDL levels of 2.5 and below, and LDL less than 1.8, if I'm not mistaken, in secondary prevention. So this is always an interesting area, isn't it? Statins, it's even picked up a lot in the mainstream press as well, isn't it? Side effects of statins, statin tolerance. So it's quite a debated area. So looking at molecules beyond statins, I think would be something that would be quite interesting, really, isn't it? And what are we looking at? Well, we're looking at two molecules in particular, bempedoic acid and inclisiran. So perhaps I'll come over to you, Amma, and tell us, what is that exactly? What is bempedoic acid?
Yeah, so you said the name right, so that's a good start. So bempedoic acid, so we know, we always have to start with statins. We talk about cholesterol lowering, don't we? And statins are HMG-CoA reductase inhibitors. So basically they work on the lipid pathways. And this pathway is actually, it starts with citric acid or citrate, and that gets broken down to those molecules and then to HMG-CoA. And then you got HMG-CoA reductase, which prevents that further breakdown and causes LDL receptors to be upregulated in the bloodstream. What bempedoic acid does, it works higher up in that pathway. So rather than waiting for it to get to acetyl-CoA, so we go to HMG-CoA to get reduced by statins, it works between citrate and prevents its conversion to acetyl-CoA. So it inhibits that enzyme citrate lyase, which breaks down citrate to acetyl-CoA. And so therefore it upregulates LDL, and it works predominantly in the liver as well. So that's why you get that benefit. And so
and Patrick, inclisiran, I suppose we don't necessarily need to know how it works, what it does. It lowers cholesterol, but any sort of top line just to introduce this molecule, I suppose.
So I mean, it's a small interfering RNA, and it's involved in inhibits ultimately the translation of the protein PCSK9. So we obviously are aware of PCSK9 inhibitors. So this does a similar sort of thing in a sense that it just instead of inhibiting, it just blocks the production of PCSK9, and therefore leads to that reduction in LDL, so or cholesterol, as you say. So, but it's and I suppose that if we were to have this conversation a little while ago, I'm aware of some of the data in these, but there's always been this issue about, where's the hard outcomes? We've got this great evidence for statins. We've got good evidence for PCSK9 inhibitors. Ezetimibe, the outcome data is not brilliant. But we got, so bempedoic acid has been, so what's going to be discussed at ESC in Amsterdam is more data from the Clear Outcomes study data. So this was published actually, I think it was presented late last year, but and it's published in the New England Journal and showed a 13% reduction in its primary outcome. So it works. There was further data, which from a primary prevention perspective, which was from the same study, but just looked at the primary prevention cohort. That was published in JAMA by Steve Nissen. So we've got good evidence that it works. So I think maybe we're going to get further information. So I'm intrigued about that. Of course, we did learn there was there are some concerns from the early studies in the sense that there was this raising of uric acid but in the studies there was actually increase in clinical gout and gallstones as well. But I think for me, I suppose and this will add further fuel in our guidelines and the ACC guidelines in statin resistance. People who are unable to take statin intolerance rather than resistance, I should say. But the first line will be ezetimibe. Well, but ezetimibe hasn't really got the outcomes. So why are we using a drug without outcomes? So this would be potentially a role for bempedoic acid. In my clinical practice, I tend to prescribe it with ezetimibe because on its own, it has relatively low lipid lowering efficacy, but it is at a population level showing benefits. So which perhaps we don't see so easily with ezetimibe, certainly on its own. So that's the thing which I suppose intrigues me, is really a little bit more about this, a bit more data. I think there's some real world data coming as well to complement it. So I think it's the and then I don't know if there's anything else you want to add on bempedoic acid, Amar, from your perspective.
No, I think...
Or we to move straight on to inclisiran.
Yeah, I think, again, we see clinically that there's relevance and there's importance of statin intolerance, true statin intolerance, I would say, in that cohort, and there's a need for that. This just adds further to that evidence base that lipid lowering and LDL lowering is good, and we'll see what else it shows. But yeah, no, nothing more to add on that.
Certainly, I've had no resistance. This is the beauty about these newer. Nobody's written any article in the Daily Mail, so I have no resistance in prescribing a brand new product without the breadth of evidence. But statins, particularly when people have had an adverse reaction to one or two, I mean, we could go on, and I mean, there is precision medicine trials going on in the UK in some general practice surgeries about genetic testing before, so you could actually identify people who are going to be intolerant based on their blood work. That would be very interesting to follow, but that's not at Amsterdam though. But I think that sort of, for me, it leads on to inclisiran, where of course we've gone from a drug which is an oral drug with modest efficacy in glucose in cholesterol lowering, but with some outcomes, and then we've got this really quite interesting product which requires, after the first injection, it's 3 months, but thereafter it's every 6 months, subcutaneous injection. And the UK government has done a deal with Novartis, so that makes it financially very affordable. And really, it's something for us to consider, really, when we need additional lipid lowering, particularly once we've given both statin and ezetimibe, or perhaps bempedoic acid and ezetimibe for those people who are statin intolerant. So, and that's actually a fair number of people based on those secondary prevention targets, which you mentioned, Amrit. So I think it's difficult to ignore this. And there's a whole load of controversy in our neck of the woods the LMC, who are our trades union almost, suggesting we shouldn't do it in primary care because it's taking up our nurses' time and there isn't the outcomes, and there's a bit of controversy there. But there's an irresistible efficacy, but in terms of lipid lowering, quite an effective treatment. But I suppose for me, it's all about those harder outcomes. We haven't had the outcome trial. That's still got to cut. We're still 2 or 3 years out before Orion 4 lands, and it's really that this gives us. I think they're looking at a cohort of patients. They almost certainly pronounce it wrong, but the Colinet registry. This gives us some real world insights, really. I don't know if we're going to have harder outcome data from that. It's obviously observational data, so it's not definitive, but it might give us those insights which might give more of us confidence to use it within in our patients who need additional lipid lowering therapy. So I'm really interested to see that.
Brilliant. And I think that, as you say, it will add so much to that area. And I suppose something that I think in primary care we will see just developing more and more over the coming years and be involved with a lot more. ESC as a congress has got other areas as well. We picked out these 2 areas, the GLP-1s and lipid management, as particular areas of interest. There are a variety of different sessions going on, some really topical ones about sudden cardiac death in sport, sports people, artificial intelligence. That's always an interesting one. But also just some, again, bread and butter sessions, blood pressure management, latest updates, things like that. So if you're there in Amsterdam, please do go and say hi to Amr, because he's going to be there as well. But also, if you're joining online, these are some of the sessions that we think will be really interesting to attend. We'll put some more details at the bottom of our video as well on the times and the dates of these sessions. But all in all, although we're cardiometabolic interest clinicians, this actually has some really interesting sessions that overlap as well. So we're looking forward to it. We'll be tweeting away. I'm sure the guys will be hot on Twitter during the conference as usual. So please do stay posted to our Twitter account during the conference. And we look forward to engaging you via there. And also, if you like this video, then please do like and subscribe to our YouTube channel as well. All the best. Thank you very much. Thanks, Patrick. Thanks, Summer. See you guys soon.